With some of those challenges in mind, it is my pleasure to introduce our next speaker. Dr. J.Wittes founded Statistics Collaborative in 1990, and since 2020, that company has been part of the WIRB Copernicus Group, or WCG. Formerly, Dr. Wittes was Chief of Biostatistics Research Branch of National Heart, Lung, and Blood Institute from 1983 to 1989. Although she's not been involved in veterinary studies, she has worked on trials of heart failure in humans and was a co-author of the report that we're all familiar with, the RAILS study, which showed benefit of spironolactone in reducing mortality in patients with New York Heart Association Class 3 and 4 heart failure. Currently, she is a member of the FDA's Circulatory System Devices Panel and a participant in the Heart Failure Collaboratory, a public-private partnership with members in academia, industry, and the FDA. Her recent research has focused on design of randomized clinical trials. She has served on a variety of advisory committees and data monitoring committees for government and industry. She's a fellow of several professional societies, and from 1994 to 1998, she was editor-in-chief of Controlled Clinical Trials. She received the Janet L. Norwood Award for Outstanding Achievement by a Woman in the Statistical Sciences in 2006, and the W.J. Dixon Award for Excellence in Statistical Consulting from the American Statistical Association in 2015. Dr. Wittes received her PhD in statistics from Harvard University in 1972. Please join me in virtually welcoming Dr. J.Wittes. Thank you.
Thank you very much for inviting me and for that lovely introduction. I'm going to try to share. I'm going to be talking about randomized clinical trials. And I want to start with a couple little comments. When I was at NHLBI, we were concerned at the time, so this was in the late 80s and the middle and late 80s, we were concerned that most of our studies were about men. And early on, and while I was there, we did a study called the Postmenopausal Estrogen Progestin Interventions Trial. And there is a cup. If you can see me, I'm using the cup here. Women have hearts too. And so when I was invited to this conference, I thought, my goodness, I guess dogs have hearts too. And was really intrigued about what the similarities were for in treating dogs and humans. I also was very intrigued that this was going to be about spironolactone, because this is how I learned about Spiro. Well, you heard from Emily this morning, you saw from Emily this morning a picture of Bert Pitt, who was the first author on the Rawls paper. We worked on it for quite a number of years, and it was pretty exciting to see an old drug reducing mortality in heart failure by 30%. And the other thing I've thought about as I was trying to put this talk together was that one huge difference, it seems to me, in animal studies than in studies of adults is that the person who is doing your informed consent is the owner of the dog, not the dog itself or himself or herself. And so in some ways, it seems to me, these have the challenges of pediatric trials in humans. My own experience with animals, I have to tell you, with animal studies is quite limited. Very few studies, in fact, I can only think of one, and that was a non-human primate. That was a trial where the important question was about the animal itself. All the other trials that I've been involved in with animals have been trials of an animal model with a view toward inference to humans to design a human study. So this is a new area for me. What I want to talk about today is start with basic principles of randomized clinical trials. Talk about the structure, the choice of control, the choice of endpoint, recruitment, randomizations, operations, and as a statistician, the statistical analysis. But then I also want to talk about what often goes wrong in human trials, and I suspect some of the problems we have in human trials you have in trials dogs. There are protocol violations and deviations. There's missing data. And then there's all kinds of problems with bias and problems in analysis. There are subgroups that we deal with and secondary outcomes. So the very simple, the simplest kind of trial is the trial that Richard Peto, it's been said that Richard Peto says this. I could not find where he said it. Randomize and count the corpses. If you can do a very simple trial, very large, a very clear endpoint, all you need to do is compare the group that you're randomizing to the group that you're studying to the group that is your control. But as you said in the questionnaire, in the poll that was just done, one of the problems that you have is getting large sample sizes. And so one of the focuses that I'm going to be talking about is how to increase the precision of your trials so that you don't need as large a trial as one would hope you would have. I want to mention type 1 error rate and power and type 2 error rate. These are the errors, the false positive and false negative rates, how to calculate sample size once over lightly, and then to talk about how to avoid bias, randomization, blinding, the kinds of analysis you do, intention to treat versus per protocol analyses and other kinds of biased analyses, and then making sure that the statistical methods that you use are, in fact, unbiased. So here's a structure of a trial. And again, one of the things you just said in the poll was that it's much harder in animal studies to have the infrastructure that we have in human studies. So here's a picture of a typical human study. There's whoever the sponsor is. There's an academic steering committee that provides advice to the sponsor. There are labs. There's a data center. There's a group of adjudicators, especially in trials of cardiology and oncology, where you want to make sure that the event that's called by the investigator is truly an event. You have your centers where you're entering, where you're seeing the dogs. There are institutional review boards to make sure the trial is ethical. And then you have the participants, who are the dogs, and their owners. And then an oversight committee. In human trials, these would be called data monitoring committees. We're looking at the data during the course of the trial to make sure that the animals are safe, that there's not something disastrously going wrong that you don't learn about until the end of the trial. And hovering over all of you are the regulators and the journals. And again, there was the talk by Dr. Daniel described a study that was done, and the regulator said it's not enough and had to redo another study. So as you're doing these trials for the purpose of registration of the intervention, it's really important to think about what will the regulators say and what will your journals say? What will the journals say? So what are the issues that you face? First, there is the choice of control. Is there a standard of care that's established that you could say every dog that's randomized to the control group gets the same standard of care? Or are you in a situation where there isn't a standard and where the control gets whatever the investigator or the vet or the I was going to say the parent, the owner says, this is what my control would be. Is it a placebo? Is it treatment on top of standard of care? The important things is that the control must be an ethical control. You don't want to have a control that's leads to such poor results that it's not fair for the animal to be given the control treatment. And it has to be attractive enough for owners to enter their pet into the trial. And I was thinking of that as I wrote that down about when you do pediatric trials, what is it that will make a parent be willing to enter a child into a randomized study? Parent has to feel that even if the child is randomized to the not to the active treatment, but to the control, that control is safe. So what are the kinds of outcomes you can have? You could have a binary outcome. For example, does the dog never or only infrequently cough versus is the cough frequent? So that's just binary. You could make it more quantitative by saying how many coughs in a day, how many coughs in a week, but the binary is yes or no. It could be a scale, an ordinal scale. So here's an example where the endpoint was a 5-point scale of demeanor. I have to say, I was fascinated reading all these scales because they're so different. They're different and the same, or they're different and analogous to the kinds of scales that I'm used to in human trials. Then there's continuous endpoints, like systolic blood pressure. And then there are time to events. For example, time to first onset of congestive heart failure, a cardiac-related death, or euthanasia. And again, I was hit by, oh my goodness, euthanasia is an endpoint that we don't really have in human trials, or we don't admit to having. So let me go to sample size, because clearly that's an issue that you all face. And here's a very fast, very short version of how to do a sample size calculation. You want 2 errors. You want to define the level of 2 errors. What is the probability that you will declare your treatment beneficial if it's no different from control? That is your type 1 error rate, or the alpha. You also want to define the probability of failing to declare benefit if the true effect is some defined value delta. So you say, I want to reduce the difference in proportion coughing from not coughing by 10%. That's my delta. What is the probability of failing to declare that benefit if the true effect is delta? And then the power is a probability, it's the obverse of declaring benefit if the true effect is delta. So that's where we start. And then the sample size is a constant that's a function of the number of groups. Do you have 2 groups, active and control, or do you have more than 2 groups, like dose 1, dose 2, dose 3, control? The alpha, the beta, so there's a constant that's a function of those 3 quantities, times the variance divided by the square of the difference. Now, this is really important to understand in your gut. When we think of numbers and we think of means, we often think in terms of variability, in terms of a standard deviation. But in sample size, we need to have the square of that. So as the variability in your system goes up, the sample size goes up as the square of the standard deviation. So variance is very important. And the difference you want to detect, the sample size goes down as a square of as the difference gets bigger and bigger, or up as the difference gets more and it gets smaller and smaller. So these are really important concepts to remember, that the sample size is an exquisite function of the square of what we usually think of as the variability, and as the square of the size of the effect. So how can we reduce sample size? in a way other than just saying, oh, I can't get this many dogs. One is to increase alpha, to say, well, I'm willing to take a bigger risk that if there's no difference between my treatment and control, that I'll make that error and I'll declare them different. I could reduce the power. I could say, well, yes, I'm interested in having a high probability of detecting a difference is real, but I'm willing to sacrifice some of that power. So those are two ways. I can remember that my formula has the variance up at the top there. I can figure out strategies to decrease the variance, and I can think about strategies for increasing the detectable difference, or the difference I want to detect. And we have many variations of those tricks. Now, how do you reduce variance? Well, simple thing is, and I say simple, none of these is simple, but measure more precisely. All right, so you want your measurement to be as precise as you can, consistent with availability and not too much expense for measurement and so forth, but don't add to your variability by sloppy measurement. If the outcome is time to event, capture all the events and capture the events when they happen. Don't be sloppy about when they happen, and don't miss events. For continuous variables, like systolic blood pressure, take multiple measures. You can reduce variability by taking multiple measures because each measurement has variability in it. And the other approach is to take measures over time and build a statistical model, smoothing out the variability. Another approach is to use efficient, so these are design approaches, right? But now, sorry, these are approaches of design. But here's approaches for how can you analyze in ways that are more efficient. If you have variables that are predictive of the outcome, you can include that in a model, and that's a covariance model. If you have a continuous variable measured over time, it would help if you spelled the word measured better, but I didn't. The standard method that people use is you look at the final value minus the baseline. You can increase the precision by saying use the final value, but baseline is a covariate. That will squeeze a little bit of power out. And still better, use longitudinal data so you're capturing data over time, reducing the variability because you have multiple measures over time. And in time to event, you can use strata. If you have binary variables, again, think of stratification by the binary variables that are predictive. If you have, and time to event, use covariates that are strongly predictive of outcome. So it's really important up front as you're thinking about how to design your study and what analysis to do, to think about what variables to collect and whether your samples should be stratified, i.e. the randomization occurs within the strata, or whether or just corrected at the end. Now, the other approach is, or another approach in time to event studies is using a composite endpoint. And that was an example that I gave before, a composite endpoint. So, and as we add more events, the hazard ratio may decrease because we're adding more noise, decreasing power, but the sample size increases, so we're increasing power. And I want to give you an example that comes from the adenoma prevention with celecoxib study. This was done, I don't know, 15 years ago, I guess. Time flies. So here's an example of a composite outcome. This was a study, the purpose of which was to look at the effect of celecoxib on preventing adenomas. But there became evidence from a Vioxx study that there was evidence that use of Vioxx increased cardiovascular events. And so it was So the celecoxib study said we need to look at what happened in celecoxib. So here are 5 events in decreasing order of, well, a combination of closeness to the hypothesis and severity. Cardiovascular death as the highest, the worst. MI as the next worst, not clinically worse than stroke, but thought of as being closer to the mechanism. Then stroke, then congestive heart failure, then angina, then cardiovascular procedure. And when we did the analysis, we specified up front that was the order we were going to look at those events. And then we looked at the hazard ratios. And you see, my goodness, we were right. Those hazard ratios, this was the hazard of those who were randomized to celecoxib versus those who were randomized to placebo. This was a blinded study. And you'll see that the hazard ratio uniformly decreased. The highest was 5 times as many people. The risk of cardiovascular death was 5 times higher in the celecoxib group than the placebo. But in the cardiovascular procedure, the ratio was only 1.7. I say only, it's still pretty bad, but still there's a real, there's a monotonicity of the hazard ratio consistent with the prior hypotheses about how close these events would be to the mechanism. But look at this. Look at the ends. The ends are the number of events. So there were 7 cardiovascular deaths. There were 19 cardiovascular deaths or MI. There were 7 more strokes, so we now have 26. 4 more who had congestive heart failure, 5 more with angina, and then 6 more cardiovascular procedure. And if you look at the right, you'll see the p-values. The p-values start not significant at CV death. They get smaller and smaller for a while as the sample size is going up. The p-value is getting smaller and smaller, 0.15, 0.07, 0.06. But then when you get to angina, adding in angina and adding in cardiovascular procedure, the p-value gets less impressive. So what is happening here? It's a balance between the putative magnitude of effect as measured by the hazard ratio, the number of events as measured by the sample size, and the sample size is pushing the evidence, making it stronger, but the lower hazard ratio is pulling the evidence down. I give this example so that when you're thinking of a composite endpoint, it's really important to think very hard up front about what you think each component of this endpoint will be and how it will contribute both to the strength of the association as measured by the hazard ratio and by the number of events you get as measured by the incidence of events. So there are other things you can do to get smaller sample sizes. You can think about innovative outcomes. They can be attractive but problematic. I don't know enough about how you treat dogs with heart failure. In human heart failure studies, there's lots of methods for dealing with, instead of time to first hospitalization for heart failure, how many hospitalizations. There are many methods dealing with the number of heart failure hospitalizations, their frequency, and the interval between them. Many methods and lots of assumptions. The other kind of events outcome that one can use is the number of days alive and out of hospital. Those are measures, and again, I don't know how you treat dogs, so I don't know if this is a measure that you would use, but this kind of measure that tries to make what would be a pretty simple and binary outcome, did you get hospitalized or not, to something quite continuous. And then there are many more complicated measures, and always you need to think about, will this be acceptable to regulate? What about during the population? So in general, a population that's too wide, too variable, may have wide variability, especially if the variability, the incidence of events is a function of that wide population, or even more problematic, if the effect of your drug differs in subgroups of the population. But a population that's too narrow may not allow you to generalize. So with Rawls, the original Rawls studies was New York Heart Association classes 3 and 4, and it left open for about 20 years the question about, what about people in New York Heart Association 2? And the Top Cat's purpose was to look at New York Heart Association 2, but there were problems that I suspect a lot of you know, with Russia and Georgia and the centers. So there were all kinds of problems, and very hard to know what the answer is. I think you have issues with breed, with size, all kinds of different kinds of issues related to the type of dog, and it's very important to think about as you're deciding who or which dogs are eligible for the trial. Can you generalize outside that population that you've randomized, or are you limited to the population that you've specified? During the course of a trial, you want some independent group, not the investigators, maybe not even the sponsor, to be looking at the trial to make sure, looking at the data from the trial, making sure that the dogs are safe. And at the end, you want your analysis to be fair. We're going to get back to this. You want to make sure that your analysis is intent to treat. You randomize to 2 groups. You need to have every dog that's randomized has to count at the end. In fact, when I once gave a course, and my students at the end of the course gave me a T-shirt that read, "Once randomized, always analyzed." That's how you have to think about it. Don't only use those dogs who complete the study, or don't only use the dogs whose parents, whose owners bring them in at all the visits they're supposed to come. Use everybody that's been randomized. Worry about missing data, and we'll talk about that, and worry about subgroups. So here's your population of interest, all kinds of dogs, different sizes, different breeds, different moods, and you randomize them. You randomize, I'm going to assume for simplicity that you just have 2 groups. You randomize them to treated and control, and presumably, if your sample size is large enough, the randomization has produced 2 identical groups on average. Now, if the sample size is too small, you might have some imbalance by chance. The crucial word there is by chance. These are chance imbalances. So you want to make sure that the sample size is large enough that when you randomize, when you get the 2 groups, they are essentially equivalent. But what if there are missing data? If there are missing data, there's some dogs that don't have the answer at the end in the treated group, and some dogs that don't have the answer to your question at the end in the control group. And now the leftover dogs, or the dogs that are in your study, are no longer identical. So we no longer have a fair comparison. And what if the proportions missing are the same? So here, notice more mistreated dogs didn't come back than control dogs. But here, the same numbers didn't come back, but it's different dogs. So even when the proportions missing are identical, we don't have a fair comparison when we have missing data. So how do you handle it? Well, the facile answer is, oh, just don't have any missing data. But of course, That's not realistic. There are all kinds of reasons why there'd be missing data, and you got to make sure to do what you can to prevent it, but there will be missing data. But what you need to do is think up front, how much missing data do you expect to have? Do you expect the reasons will be for missing, and how you're going to analyze the data? And then after your analysis, after the study, check the sensitivity of the results to make sure that those dogs who didn't have their answer at the end that the inference from your study would be the same under a variety of assumptions about what might have happened to those dogs. Now I want to jump to subgroups and talk about three dualities. I'm going to call baseline subgroups versus improper subgroups, pre-specified subgroups versus not pre-specified subgroups, and subgroups defined by strata and those that are not. And these are, I think, very important because we often look at subgroups, and these three dualities are, at least in human studies, people confuse. So what's a baseline stratum? It's something measured before baseline, the age, the sex, the level of symptoms for you, the breed. Those are measured before baseline. Those are baseline subgroups. Then there are those present at baseline but measured later. You take a sample, a blood sample, you put it in the freezer, you measure it later. So it was measured later, but it really occurred at baseline. Those are all baseline subgroups. And those are unbiased in the sense that if your sample size were infinite, your results would be true. Now, the sample size isn't infinite, so the results may not be true, but conceptually, if you could make that subgroup infinitely large, your answer would be right. An improper subgroup is one measured after baseline. So let's say you randomize your dogs to treated and control, and you say, I'm only going to look at those dogs whose appetite is good 2 weeks after start of therapy. So now I don't have a baseline. I'm not based on baseline. The appetite 2 weeks after start of therapy could be a function of the therapy. So it's by very nature biased. And if your sample size were infinite, your results would still not necessarily be true because there's a structural bias in there. So very important to separate subgroups that are based on baseline data, i.e. pre-randomization data, from subgroups based on something that happened after randomization. Why are baseline subgroups okay? So let's say you have breed A, a set of breeds A and a set of breeds B, treated and controlled, and the left hand is the treated group, the right hand is the control group. And you could, if you saw a result in breed A, in the set of breeds A, you could do a trial, take that subgroup, do another trial, redo it, and you could confirm the data. But if you have improper subgroups, e.g. responders versus non-responders, dogs whose diets improve versus dogs whose diet don't, you don't know in the treated group, here we have responders, you do not know who in the control group, which dogs would have been responders. So you can't look at the responders, you don't know they're the same. What you would have to do is ask which ones in the control group would have responded, and conversely, in the responders in the control group, you would have to ask in the treated group who would have responded had they been in the control group, and those are unknown. So how would you confirm this? Well, you could give the treatment, identify responders, and then randomize the responders to treatment or control. So you would know, okay, let me see what happens to responders if I've given them treatment or control, rather than asking if I give them to treatment control and then they respond, what happens to them? I want to show you a little, this is a picture from my friend Bob's Byington of subgroups from the SHEP trial, the systolic hypertension in the elderly trial, where the overall, the endpoint was fatal and non-fatal stroke, and the overall effect size, that vertical line, was the relative risk was about 0.7. I'm sorry, the relative risk here is 0.7. Yeah, and this line is the line at unity. Unfortunately, the 1 isn't where it belongs. What you see in the very large subgroups, the subgroup effects are clustered around the overall effect, not surprisingly, because the very large subgroups are very close to the total population. In the moderate sized subgroups, they're clustered, those are the red ones, they're spread around. As you move down to the smaller subgroups, the spread gets wider and wider, but they kind of still all show benefit. When you get to the tiny subgroups, and here they are, and I'm laughing because these tiny subgroups are 1,000 people, right? They're not tiny in the sense that they're not like 7 or 8, they're huge. But what you see is huge variability, and when the subgroups are really small, you see here, this is really beneficial, tremendously beneficial, and here, really harmful. Basically, this is noise. So the message is that the smaller the subgroup, the less reliable the data, the results are. Okay, what are tricks to gain? Oh, and let me just mention a little bit about my other 2 dualities. If you have subgroups that you don't pre-specify, you look at your data and you say, oh, look, this looks good or this looks bad. You don't pre-specify that. That's like shooting an arrow, shooting lots of arrows at a target, and every so often one hits, and you say, what a good shot am I? You have to pre-specify. And then there's an issue of subgroups. Of strata. If you stratify, there are some people that say, if you stratify, that means you've made a hypothesis. And if you don't stratify, it means you haven't. That's not true. Stratification, think of as a method for increasing precision, making your study more efficient. That's different from, and I want to ask my questions in subgroups. So keep those 2 separate. So how can you gain statistical power? You can use composite outcomes, but as I said before, you have to be careful that you don't use outcomes that are so variable and so too unrelated to the mechanism that you're adding noise. You can use surrogate outcomes if you're really comfortable that those surrogate outcomes are closely predictive of a clinical outcome. You can do covariate adjustment, as I said before, and unconventional outcomes that are well thought out. You can use larger type 1 error rates, or you can say, I'll take a risk that, I'll take a higher risk of making an error, or use lower power. And there are more tricks. You can cheat unknowingly. You can use multiple outcomes, and you see this in human trials all the time, a whole long list of outcomes, but nothing's pre-specified and nothing's corrected for multiplicity. So that's a little bit like my subgroup. If I have too many outcomes and I haven't pre-specified what's what, I can't be able to quantify in a rigorous way. I can use bias analyses, and people do this all the time. Compare responders versus non-responders, and we've just seen, no, don't do that. That gives you more power, but it gives you more power in a biased way. You could do a completer analysis. You can say, I'm only interested in the dogs that completed my study. Again, you see this in human trials all the time. But that's biased because the dogs that complete the study on the treatment may not be the dogs who would have completed the study on the control, and vice versa. And there are still more tricks. You can deliberately cheat. So here's some examples of deliberately cheating. You can paint these are all real examples. You can paint your mice, like Summerlin did. You can make up data on dogs, like Darcy did. I want to stress that the Darcy who did this was not the same Darcy as Dr. Daniel spoke. It's a different Darcy. But he just made up dogs, and this was I guess in like 1982, famous case. You can invent patients. This is Biswota from South Africa, just made up patients, and it was pretty scandalous. And I tried to see whether these are, whether it was an example of a veterinarian who's cheated, and at least one has cheated in a study that was to look at treatment in animals, and that should have been at least one, not at least on. So I'm going to make a plea. Oh, and I do want to say, while the talks were going on this morning, I got an email that said, so here's this cheat deliberately, a seminar that's going to be given next week on fraudulent trials in systematic reviews, a major public health problem. So these kind of deliberate cheats are not only in the past, and they're more common than we would like. So here's a plea. My plea is, make sure you design up front. This poem is W.H. Auden in 1946. It's the Harvard Phi Beta Kappa poem. The guys had just come back from the war, from World War II, and he gave a lecture, but the lecture was a long poem, and it ended with a decalogue with 10 commandments to say to them, basically, the liar were Mercury and Zeus. They were should you be free and do light things, or should you be ponderous? And at the end, the last lines were, thou shalt not answer questionnaires or quizzes upon world affairs, nor with compliance take any test. Thou shalt not sit with statisticians. And I hope you won't listen to that. I hope you will sit with statisticians as you're designing your study, making sure that you explain the trial to the statistician, and the statistician explains the methods that he or she is using. And plan. If you fail, this is from Benjamin Franklin, if you fail to plan, you're planning to fail. Make sure you plan. Don't make your decisions about how you're going to analyze the data after the data come in. I thank you very much for listening, and I'm happy to field questions.
Thank you so much, Dr. Wittes. That was a wonderful talk, a lot of food for thought. If everyone wants to go ahead and put questions either in the chat or in the Q&A, we have a question from Dr. Atkins. As you know, financial constraints in veterinary medicine limit population sizes in clinical trials. Would you please comment on the ethics and utility of publishing negative results from underpowered clinical trials?
That's a wonderful question. I think it is important to publish negative results. And I actually don't like the concept of positive and negative results, because often we say a negative result is something that doesn't show statistical significance, and a positive trial is something that does show statistical significance. To me, you've got results of trials, and you should publish them. I think it's not ethical to take animals and to do experiments on them and then not to publish the results. But you need to be honest in your discussion of what the power of your study had been, what the effect size you were testing, what conclusions you can make. So it's always harder to write up a study that doesn't show what you wanted it to show than a study that does show what you want it to show. But I do think you should publish. It's an obligation to publish, and I think that journals should be more willing to accept studies that don't don't show what the hope had been.
Thank you, thank you. I have a question that relates to primary versus secondary endpoints for trials. I was really interested in your discussion about choice of composite versus individual endpoints, and that's definitely a lot to think about increasing noise, but also increasing sample size. And that got me thinking about our choice of what we decide to label as our primary endpoint versus others. Obviously, we power primarily for the primary endpoint, but if you have multiple endpoints that you are technically powered to show, my impression is that if you fail to show a primary endpoint significance but do show secondary, people kind of look down on the trial and say, well, but they failed their primary endpoint. Any thoughts about choice of primary versus secondary and how that's perceived versus the actual value and science in that?
Okay, sure. Also an excellent question and very difficult. So the conventional approach is this. You choose a primary endpoint, you size your study for the primary endpoint, and the trial is up or down depending on the primary. And then you have a bunch of secondaries, which you may or may not control for alpha. What I like to do is I say, don't give me a list of 40 secondaries, because giving a long, long list of secondaries, my friend David Zucker, who's now at the University of Jerusalem University, he always would say to me, too many hypotheses is the same, or many, many hypotheses is the same as having no hypothesis. So if you have lots and lots of endpoints where you don't structure them in any way, well, then that's a little bit like throwing a dart and 100 times and getting the bullseye once and saying, I'm a great shot. What I like to do is and lots of people object to this, but to say, okay, you want a bunch of secondaries. Let's first of all figure out those that have at least 50% power. Because if they have less than 50% power, and why 50%? 50% is actually a magic number. If you say, I'm hypothesizing a certain difference, delta, and if I see that if my study shows delta and I have 50% power, that's the barely significant difference. So 50% power and the delta that you choose for that endpoint are intimately related. So what I say is go through, choose the ones that have high power, and then figure out a way of adjusting your type 1 error rate in a way that you can actually make formal inference. Now, that still doesn't answer your question, because your question is, all right, suppose you do all that and your primary doesn't hit, but this nicely structured secondary is telling a story. I think that it is a matter of judgment then. And depending on how much the primary didn't hit and how strongly the secondaries did hit, that may be a case. Or you might say, my goodness, that primary was not really a good endpoint. I'm going to replicate my study using the secondaries. But the more structure you have for those secondaries, the more likely you are to be able to make formal inference.
Excellent. Thank you very much. Mm-hmm. We'll welcome a couple more questions in the chat, and while we're waiting for those, I'll follow up that question with a similar one to which I think I already know the answer, which is similar question about a subgroup positive result, or not a subgroup results that is significant in the way you've structured it, whereas an overall population result wasn't significant. In our world, it is relatively unlikely that we will be able to replicate the trial in each individual subgroup, for example, in an individual breed. We absolutely would love to do it, but I assume it just also then becomes a judgment call about, do we just accept those results of a larger trial if there is a subgroup effect, if we can't replicate that study?
Yes, it's a matter of judgment, but I think if you take my slide, Bob Byington's slide of the SHEP, it creates for me a warning. right? Because if you have a very small subgroup, so here's what will happen. You can have a very small subgroup with a dramatic result. And people will say, my goodness, this must be real because it's so small and the result is so dramatic. But in fact, it works the other way around. If there's no effect at all, if you're operating under the null hypothesis where the treatment has no effect, the probability of finding something, falsely finding something, if you're dealing at an 0.5 level, which most people do, is 5%. And it's 5% whether the subgroup is big or the subgroup is small. But the only way to get a p-value less than 0.5 with a small subgroup is if the effect size is very big, what you see. So you're deceived so this kind of subgroup can be very deceptive because you'll see this tiny little subgroup with this wonderful effect. So it seems to me what you have to do is you have to think of the biology, and it's useful to think of the biology before you see the subgroup, because it's very easy to make a conclusion about a biological explanation after you see the fact. So if you want to think about subgroups, again, if you structure them, I have these 5 different breeds. This is why I think the drug will work better in this breed and that. Big structure as much as you can up front, so it doesn't look as if, and you don't fool yourself. You don't fool yourself by making up a hypothesis to fit what you've seen.
Thank you very much. We have another question from Dr. Atkins, which is a sobering thought. The largest clinical trial to date at least in cardiology in veterinary medicine is 569 dogs. Most large veterinary trials have more like 200. In an overview of that fact, will you comment on the likelihood of our ever being able to prove anything but the most major benefits of a drug or intervention? Dr. Atkins mentions he thinks that using a p-value of 0.1 would be one way to help this, but would be looked down upon by colleagues.
Right, so I agree that sacrificing the p-values and sacrificing the power are good strategies. I do agree with that. And remember, these numbers, where did 0.5 come from? It came because back at the time they were building the biometrica tables for statisticians, they had to do all the calculations by hand. And so they chose 3 numbers. They chose 0.1, 0.5, and 0.1. That's where they came from. So there's no science behind that. But the other thing you can do is, and I've just mentioned it on a point, but I didn't say anything, is use surrogates, right? And think of the way in which in human trials, orphan diseases are studied, that much more attention is made to surrogate outcomes if you can really clearly and intellectually honestly link that surrogate to a clinical outcome. Now, there will be people I know that would criticize that. They'll say you can't, surrogates are problems. Yes, they are, but I think that is a reasonable strategy if you really understand the biology. And again, depending on how close the biology in the dog is to the human, you might be able to use inferences from the way the biology works in humans to the way the biology may work in dogs.
Thank you. We have a comment from Dr. Moschel, and more to come on this topic in a moment, that optimal trial design and mathematical modeling is another way to deal with small sample sizes, but I'll leave that for our next discussion. And then we have another question from Dr. Dennis. Due to the acknowledged difficulty of undertaking randomized controlled trials in veterinary medicine, we have a large number of published observational studies. Furthermore, these studies rarely reach criteria such as those proposed by Bradford Hill. Rather than use these studies to generate hypotheses to be tested, we often use these results to guide our clinical practice. which is unfortunate. Do you have any advice for this problem?
Boy, are you coming to the wrong person with that. I don't know anything about observational studies in dogs, but I do know, or in veterinary medicine in general, but I do know how many major mistakes were made by using observational studies in humans. The litany is long. There's, of course, postmenopausal estrogens. There's antioxidants. The basic message in humans is that people who take care of themselves and are wealthy take all kinds of medicines and all kinds of prevention and do all kinds of exercise, and they do well. And then when you test them against a randomized control, it doesn't work. So I would be very skeptical of observational studies, but I'm generalizing from what I know in humans.
Wonderful. Well, thank you so much, Dr. Wittes. I think we will go ahead and do our virtual applause. Thank you.
Well, and thank you for having me.